Dear colleagues, welcome to today's EACVI Premium webinar on how and why to measure RV and LA strain according to EACVI standards and industry task force activities. I am Professor Kristina Høgbo from Oslo University Hospital, Norway, and I have the pleasure of being joined by Professor Luigi Badano from the Italian Institute of Auxologico, Milan, Italy, and Professor Jens Ove Vogt from Leuven University Hospital, Belgium. The aim of this webinar is to give you a better understanding of the quantification of RV and LA myocardial strain through clinical cases during the presentations. And we will learn which parameters to use for clinical purposes. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate online during the sessions in the form of multiple choice questions that will be submitted during the presentations. And so I will now hand over to you, Professor Badano, for the presentation.
Thank you, Kristina, Jens Ove, colleagues. In the next 20 minutes, I would like to share with you some ideas about why we have to implement the right ventricular strain in the routine of the echo lab and how to do that. My first slide is about my disclosures that are listed here, and then I would like to start with a summary of the pros about the right ventricular myocardial deformation imaging and the right ventricular myocardial strain. First of all, it is an angle-independent method that is based on routine grayscale 2D images. That means that we have overcome all the limitations of the strain derived by the tissue velocity imaging, and we can use routinely acquired grayscale images to quantitate right ventricular function. It's very sensitive and very fast measurements of both global and segmental longitudinal right ventricular function, and we know that the longitudinal function is one of the main determinants of the overall pump function of the right ventricle. It's important because strain measures the actual myocardial deformation, and so discriminates the myocardial function from displacement and tethering. It's less loads dependent than velocities and ejection fraction, and so can be used in overloaded ventricle, like in conditions like pulmonary hypertension or severe volume overload, like severe tricuspid regurgitation, and then provides also additional parameters like the regional amplitude and the timing, and we will see how right ventricular dysynchrony is a less known parameter than the left ventricular dysynchrony, but it's important in the prognostic determinants of our patients. Just to set the stage, I will start with the three very quick cases. On the left, you see an echo, a 4-chamber view of a healthy volunteer. In the center, there is a right ventricle of a severe volume overload of the right ventricle, severe tricuspid regurgitation. And on the right, a patient with pressure overload of the right ventricle, an hypertrophied right ventricle due to pulmonary artery hypertension. If we measure the function of this ventricle using one of the most popular parameter, that is the TAPSE, we see that in the diseased ventricle, the TAPSE is slightly reduced compared to the healthy volunteers, but it's still in the range of normality. And particularly, the numbers are exactly the same between the tricuspid regurgitation patients and the pulmonary hypertension. What can add the measurements of right ventricular strain in patients like those? We see the same ventricle that examined with the right ventricular strain, and we see that for the healthy subject on the left, the global strain is absolutely normal, -22. In a patient with the volume overload is normal or even higher than normal as expected for volume overload, but in a patient with pulmonary hypertension, despite the TAPS was not reduced, we see that we have a moderate reduction of the myocardial function. And this is exactly the point, the ability of differentiate the different pathophysiology of the right ventricular function or dysfunction. This is a very elegant study by Sorin Juska from the group of Professor Faut, showing the added value of strain compared to TAPS. Those are a very unique cohort of patients with pulmonary hypertension due to thromboembolism. And they underwent pulmonary endarterectomy, and they looked at the right ventricular function before the pulmonary endarterectomy, 1 week after the operation, and then 6 months. And you see that before the operation, there is a very small left ventricle that is actively contracting because it is empty and is tethering the right ventricle. So the wide motion of the right ventricle is not due to the active contractility, but is tethered, pulled by the actively contracted left ventricle. When we remove the pulmonary afterload, there is a filling of the left ventricle that increases in size, reduces the active contractility, and also the right ventricle function seems to be diminished. And even more during the long follow-up of 6 months, now the left ventricle has regained the normal volumes and function, and you see that the right ventricle seems to be dysfunctioning compared to the preoperative. We can look at these images with the tracing of the different components. Here you see the curve of the TAPS, that you see that the preoperative we have a very large TAPS that is due to the large apical rotation that we have in this ventricle, while the strain is really low. When after the operation, despite the remotion of the afterload, we have a dramatic reduction of the TAPS, and this is mainly due to the fact that the apex of the left ventricle is regaining its overall function. But you see that despite the dramatic reduction of TAPS in these, the strain remains unchanged or even increased. But at 6 months, despite no detectable changes in the TAPS, you have a full recovery of the myocardial function, showed by the increase of the strain values, both at midwall and basal strain. Here you see that there is this discordance between the TAPS, that is a measure of longitudinal function of the right ventricle according to an external reference, compared to the actual measurements of the function of the right ventricular myocardium. Then we go to another case. This is a patient with severe functional tricuspid regurgitation, so volume overload. Okay, the question here in patients like this is that usually you have a normal right ventricular ejection fraction, but you don't know if the right ventricle is really suffering. So here it is crucial to assess the function of the myocardium, also to set the timing for any intervention. And here is where it comes the role of right ventricular strain. Basically, in these patients, we have a normal ejection fraction that is 61%, but when we look at the strain, despite the normal ejection fraction, the myocardial function is reduced with a 12%, here is, with 12% of the longitudinal strain, showing how you can assess the myocardial function. And after this case, that I think it's really paradigmatic of the role of the assessment of myocardial function compared to ejection fraction, we can look at the first question for our colleagues who are attending this webinar. And the question is why longitudinal strain by speckle tracking provides a better estimate of right ventricular myocardial function than ejection fraction. You can choose between 4 possible answers. The first one is because it's less load dependent than ejection fraction. The second one is that because it's a pure measure of myocardial contractility. The third choice is because strain is independent on pulmonary pressure. And the final one is that because the strain is independent on TAPSE. Make your choice.
Very nice, Luigi. In the meantime, maybe I think that all these questions, all these answers, better to say, might be a possible option, but you are convinced that there is one correct answer.
Yeah, they may be possible options, and I have put them in a little tricky way in order to challenge our friends, because one is the really correct one. The other are possible, but we can discuss about that.
Okay, so then we also have the answers, and 46% say that it is less load dependent than ejection fraction. 42% say it's a measure of myocardial contractility, 5% independent of pulmonary pressure, and 8% independent on TAPSE. So the 2 first answers were maybe even equally well or equally frequent.
Yes, this is very nice because allows us to point out one important point. That's true, the first one, because strain is less load dependent than ejection fraction, but it's not completely load independent. And this is the point against that is independent on pulmonary pressure. Still, there is a certain load dependency. And the second one, strain is not a measure of myocardial contractility. Strain rate, it will be closer to pure myocardial contractility. Strain is just a measure of myocardial function, but still dependent on some loading conditions. Now we go, if we understand that we should use it, now we go to how we should assess right ventricular strain. And the first question that comes in the EchoLab is which view I should use among the different views of the right ventricle that I can obtain. The main ones are shown in this slide: the typical, the classical apical 4-chamber view, the right ventricular modified apical 4-chamber view, and this right ventricular focused apical 4-chamber view. And this is one of the questions that has been answered in the consensus document that we have prepared with the group of the European Association of Cardiovascular Imaging, joint with the American Society of Echocardiography and all the industries and manufacturers of echo machines, to try to standardize how we should measure the right ventricular strain and also the atrial strain. The first and important point is that we should not use the classical 4-chamber view, because with this view is more difficult to be standardized, and also usually we don't see the apex of the right ventricle. So this should not be used. What we should do is to move the probe a little bit laterally compared to the classical 4-chamber view, more towards the right shoulder, to obtain a true right ventricular focused 4-chamber view. This is the only view that allows to see the right ventricle in this larger area, and almost in all patients you have the entire free wall till the apex inside of the view. Then we have to take into account that the right ventricular free wall is really thin, so the region of interest should be small, no more than 5 millimeters, or if your software package has a dedicated endocardial contour tour, you can just use that, because we don't measure the radial strain due to the thinness of these. The important point is to avoid to encompass the pericardium within the region of interest, because the pericardium is very bright, attracts the software, but also is inextensible. And so if you include the pericardium, you will have an underestimation of your strain. About what to measure, for sure the free wall longitudinal strain is the parameter that has been more studied in literature, and the one we have more prognostic and diagnostic data. The four-chamber right ventricular longitudinal strain, that means including the interventricular septum in the computation of the longitudinal strain, can be used not for prognostic power of the parameter, but to better understand the pathophysiology of the right ventricular dysfunction. We confirmed that the radial strain is unreliable because the wall is very thin, but since the mechanics of the right ventricle is a little bit more complex than just the longitudinal motion of the tricuspid plane, we have also included in the recommended parameter the longitudinal and the radial displacement of the endocardium. Just to understand what is normal, what's abnormal, we have also available the normal values that have been obtained from a relatively large population of healthy volunteers a few years ago have been published. And what's important to remember here is that the strain measured at the free wall is always larger than the strain measured at the septum. And when we obtain the so-called global or four-chamber right ventricular strain, that is the average between the two, the values are lower than measuring the free wall. So when we write on our report, or echo report, right ventricular strain, we should indicate if it is just free wall or the four-chamber one to understand the value of the parameter, and also to improve the reproducibility and the comparability of the measurements. It's feasible because both in normal subjects and in patients, the feasibility is higher than 85%. It just depends on the acoustic window, but if you have a decent acoustic window, it's easy to measure exactly as the left ventricular strain. One other point about the normal values is that there is a difference between men and women, and as usual, women have a better myocardial deformation than men. This is exactly what happens on the left. And for both the genders, the values at the right ventricular free wall are higher than at the global or four-chamber, just to underline once again this important point. There is no relationship with the age, so it doesn't increase and decreases with the age, so this can be discarded. So just to put in perspective, to summarize, there is at least a 2 percentage point of difference in strain between men and women, and there are at least 5 percentage point in difference between global four-chamber or free wall strain. And this just to understand the difference that they are there. When we try to define if it is normal or abnormal, so we have to pay attention how we have measured the strain, the gender of our patients, and also the vendor, unless we have a specific software for measuring the deformation, as we will see. And now comes my second question. And the question is that's an important one, when we say that the right ventricular free wall longitudinal strain is abnormal, when it is less than 17%, when it is less than minus 20%, when it is less than minus 25 or minus 30%.
Very good. In the meantime, Luigi, there are, I think, hundreds of questions here. I can ask some of them while we are waiting. Does the respiratory cycle influence on RV longitudinal strain?
I have no evidence about that. This is really interesting. I have never tested that. I don't think so, at least in normal subjects where there is no, but probably in patients with severe tricuspid regurgitation, it's likely that could be, because it's changing the loading condition of the right ventricle.
So here come the results. 14% said the first option, -17. The second option, 41%. Third option, 30%. And fourth option, 15. So the most of the colleagues voted for number 2.
-20%. That indeed is the right answer. This is the lower limits of normality of right ventricular strain so far. I told you that sometimes instead of the free wall, we measure the so-called global or 4-chamber strain, because we are looking at the pathophysiology of the right ventricular dysfunction. And we have learned that the right ventricle has a different ability to adapt to, for example, the pressure overload. As you can see in these quite complex slides, there are 4 different patients. All of them have a pulmonary hypertension. The first, the upper left is pulmonary hypertension in a dilated cardiomyopathy, and you see that this affects the function of the right ventricle. The global strain is severely reduced. But if you have, and also is severely reduced in patients with the pulmonary artery hypertension. But if you have a congenital disease like pulmonary valve stenosis or Eisenmenger syndrome, despite similar pressure overload, the right ventricle adapts very well, and the strain is remain preserved. So this is just to say that looking at the mechanics of the right ventricle allows us to better differentiate some pathophysiological points. And this is another example of that. You have 2 dysfunctioning right ventricles. You see that the global strain is 11 in a patient with severe pulmonary hypertension, is -10 in a patient with dilated cardiomyopathy. But if we look at the regional distribution of the strain, we see that the dysfunction is mostly in the free wall in patients with severe pulmonary hypertension, while is mostly in the septum, so in the left side in patients with dilated cardiomyopathy. This tells us that we need to know how to use the different options in our software. And just to finish with a few slides showing the prognostic value of the right ventricular strain. The most studied is in patients with pulmonary hypertension, and of course in patients with decreased free wall strain and pulmonary hypertension, there is a decreased survival, and this has been shown by many studies. And also this is the largest one from the Mayo Clinic, of more than 400 patients in the different groups, showing that the free wall strain was a strong determinant of the time free to cardiac events and also the time free to medical interventions. And according to the different cutoffs, you see more severe is the dysfunction, more severe is the prognosis of those patients. In pulmonary hypertension, there are a lot of studies. I have just summarized them in these slides. We don't need to read that, but just to see how active is the research in this field. Another very interesting area of use of right ventricular strain is in the selection of patients for the implantation of the VAD. You know that one of the most catastrophic events after the implantation of the VAD is the failure of the right ventricle, and this is a very difficult task for the clinicians. This study by the group of Matteo Camelli in Siena showed that the right ventricular free strain is better than the global right ventricular strain, and also the sphericity, the shape of the right ventricle, are high predictor of outcome. And these data have been confirmed independently by the group of Magunia and co-workers in a recent work, showing that the right ventricular strain is better, the right ventricular ejection fraction measured with the 3D in predicting the outcome after LVAD implantation. And when they compared the ROC curve between the two, you see that the strain has an area under the curve of 91% that is significantly higher than the one of right ventricular ejection fraction. Finally, not only the value of the strain, but also looking at the regional strain component, at the dispersion of the contraction. This is an interesting study by Dr. Sarvari, the group of Cristina Auga, showing that the time to minimum strain, when it is the dispersion of this timing across the different segments of the right ventricle, is a predictor of the occurrence of arrhythmias in a patient with arrhythmogenic right ventricular cardiomyopathy. So it's a predictor of the arrhythmic risk in those patients. And finally, not only in selected populations, but this recent study from Mara Gavazzoni from our lab showed that also in the general population of patients coming to the echo lab, the strain is a strong predictor of survival and hospitalization for right heart failure. And what was really interesting is the graph on the right, showing that even in a patient with a normal TAPSE, still the strain can differentiate those with the worst prognosis among them. I am really happy to show this slide. It's not to publicize anything, but just to say that the efforts of the strain standardization have been followed by the industry, that for the first time, at least that I know, instead of producing a software tool and then look for a clinical validation or a clinical use of that, now they have produced a software tool under the request and under the specification of the clinicians, and this is the dedicated tool to measure the strain of the right ventricle. Finally, just one word to say that the future is for the 3D strain. This is an interesting study from the group of the Hammersmith that showed that the 3D strain can be able to quantify the different components of myocardial deformation in patients with pulmonary hypertension and to predict survival in those patients. Then to conclude that with a few comments that I hope I have been able to share with you, that the right ventricular longitudinal strain is objective, is sensitive, and is less load-dependent matrix of right ventricular function. Remember that the right ventricular strain measurements are affected by gender and also by the definition of the computation, different if we measure the free wall or the four-chamber strain. Then the right ventricular strain is important because it's related to the disease severity and also to the outcome of our patients. And then opens a new way of stratifying the arrhythmic risk, looking at the synchrony of the right ventricle. And then if you want to learn more about the strain, you can join Dr. Muraro and me in the deformation course in Milan. That is a nice city in Italy. Thank you very much for your kind attention.
Thank you very, very much, Luigi. I think this is a very interesting topic, and I think it's highly, when we look at the community, there are very, very many questions, very many clinical questions. So one of the key questions is, of course, the very clinical one. It's from Belgium. Do we assess RV strain in every patient or in selected patients? What would you say?
I would say that at least we should do it in a patient with pulmonary hypertension and in patients with extreme loading condition of the right ventricle. But as far as we have seen that there is a prognostic value also in the general population of our patients, and since it is very easy and quick to be assessed, we are using routinely in every patient.
Yeah, and also maybe when you suspect from your visual assessment but you're not sure,
exactly.
Strain is very good at confirming what you think you see. I think that by then there are very many questions, and for the audience they will be answered afterwards online. So we need to move on, I think. But thank you again, Luigi. Very, very nice. And by that, we will start with Jens Ove. So please, Jens Ove, you will tell us about the left atrial strain.
Thank you very much, Christina. Ladies and gentlemen, good evening. The next presentation will be about another chamber of the heart, which was also mentioned in the guidelines, and this is the atrium and how we measure and why we measure strain in the atrium. These are my disclosures. And I would like to start with a case. This is a patient of 57 years who is known with a coronary artery disease. He had a bypass surgery a few years ago, and despite everything is fine with his coronaries, despite he's a very compliant patient who lost weight and who does sport, he still has moderate or mild breathlessness on exercise, and he has some pretibial edema. And when you look at the images, then you see that the ejection fraction is good, the global strain is good. But when you look at the diastolic parameters, you notice that there's something weird going on. There's a high E wave, but the A wave is hardly visible, although this patient is in sinus rhythm. As you can see on the tissue Doppler underneath, there are definitely two peaks in diastole, but also here the A peak is very low, E prime 11, E over E prime also 11. So what's wrong with this patient? I would like you to keep that in mind. I will come later to that during my presentation and give you the answer what was going on. But now we are going to talk about atrial function and how we can assess atrial function. I would like to start with the phases of the atrial cycle. And I think although we want to talk about echocardiography, we would like to see that, or we can see that also very nicely in the MRI images. And when we cut this MRI movie into pieces, then we can see very clearly what the atrium is doing. If you observe the atrium here in that region of the image, you see that during systole, it sort of collects blood while the ventricle is contracting. In this early part of diastole, it's not just emptying into the ventricle. You can also see the bloodstream that it's going on, and you can also see very nicely how the left ventricle slides over this column of blood. So there's more than just the volume of the atrium emptying into the ventricle. It's also blood coming through the veins. That's a conduit function of the atrium. And then if you look at the very last part, this is the contraction after the P wave. Here you see how the last bit of blood is pushed into the ventricle. And these three phases are reflected or can be observed in the atrium, and they all contribute to the filling of the ventricle. In the reservoir phase, it's about 40% of the volume, and this is emptied during the early during the early diastole, plus on top a certain amount of volume that just goes through the atrium, which is around 35%. And during the contraction phase, we have another 25%, so 1/4 up to 1/3 of cardiac function is dependent on this booster pump function of the left atrium. When we look at the ventricular of the atrial volumes, then we cannot see these things so clearly because this is just the volume of the atrium. This is not the blood volume that's going through. So in the volume curve, the early and the late diastolic volume add up to the reservoir volume that we can measure during systole. This is a big difference between the blood that is going through the atrium and the volume that we can measure in imaging. How can we measure strain? This is actually the main topic of tonight's talks, and I would also like to refer to this consensus paper which has been published last year on standardization of left atrial and right ventricular strain. and I will refer in the following to that paper. When we think of the left atrium, it's a rather complex structure with some anatomical peculiarities. For example, we do not really have a nice contour. It's interrupted by things like the atrial appendage or by the pulmonary veins. So if we want to measure like a global strain of the atrium, then we have to deal with this interrupted contour. And therefore, the definition of atrial global longitudinal strain is that we measure the length change of the myocardium, thought as a line that runs from the mitral ring to the mitral ring around the contour of the atrium. This line should just interpolate the gaps which are caused by the incoming veins and the appendage. And in contrast to the ventricular strains, we do not distinguish layers. So the endocardial is as good as the midwall because the walls of the atrium are so thin that it doesn't make a difference. So we have just one type of strain that we can measure in the atrium. And then we get a strain curve, and we recognized that this strain curve looks very similar to the volume curve we have seen before, and it shows us the three phases: the reservoir phase during systole, and then in early diastole, the conduit phase. Usually there's a flat part in the diastasis, and you have another downslope of the curve in the contraction phase of the atrium. How do we measure strain in such a curve? We start with the baseline, which is at 0, and that's usually set at end diastole. And then we measure two other points. One point is at the maximum deflection of the curve, which is shown here with a yellow dot, and then a second point right before the onset of this downslope when the contraction of the atrium begins. And in this way, we can measure three different strain values. The first is the difference between the end systolic and the baseline value, and this is the reservoir strain. And then we calculate a difference between this pre-contraction point and the peak, which is the conduction strain, and then we have the contraction strain, which is between the baseline and the pre-contraction point. So you see, in that way, we have positive values in the reservoir phase, and we get negative values in the conduit and the contraction phase. And this is also the meaning of it, because in the first phase, the atrium gets bigger, so it should be a positive value. And in the other phases, it gets smaller, so the values should be negative. Similar to the ventricle, we can have some conventions how to do that. The image acquisition should be a 4-chamber view, maybe also a 2-chamber view to measure the atrium. The region of interest should be set very thin in the range of 3 millimeters. We do not consider layers, and the full wall and the endocardial are considered equal in this anatomical structure. The parameters that we measure are only global longitudinal strain. We do not look into regional strain because of these of the difficult scanning situation in the far field of the image, because of the gaps that we have in the contour. It is not useful to make distinctions of segments or so. So we just consider the deformation of the entire atrial contour. And to repeat that again, it's important to see all these strains as differences between two measurement positions, so that we have 3 values in the end. Luckily, all these measurements and calculations are much easier nowadays, because also here in that field we have now new software that enables us to measure strain directly. In the past, a lot of studies have been done by misusing left ventricular strain applications to the left atrium. But nowadays we have more and more companies coming up with software that allows us to measure these things directly, and we also get these values there directly, so that we do not need to care about all these details. If you want to know about normal values, you find several studies in the literature that tell you that. I report here from a big study with more than 2,500 healthy individuals. 40 studies were analyzed in this meta-analysis, And what you can remember is that there is a reservoir strain, so the systolic part of the curve, which is around 40%, and the conduit strain and the contraction strain should add up to the same value, and they are in the range of 23 and 17%. This study did not report standard deviations since it was a meta-analysis, but the standard deviations are rather high, so you should think of values in the range of 10%. So if we want to define cutoff values like lower limit of normal or so, we are far away from that normal value. Another question that comes up very often is how should we define the zero strain reference? Where should be our baseline? And should it be end-systolic or pre-contraction? The recommended method, according to this recommendation paper, is that we put our baseline, our zero reference at end diastole. The idea is that end diastole is an easy thing to determine because we have the QRS, we have a mitral valve closure, we have different ways of doing that, and it's just the nadir of the curve. Also, that would be a potential definition. There are arguments to do it differently. We could also think about putting the reference to the pre-contraction state, because you could consider that as the natural resting state of the atrium, and from that on it contracts and gets smaller so that it gets a negative value. This is a valid thought. However, it doesn't change anything on the curve except that the curve amplitude becomes a bit lower. You have seen that when I switch between the slides, that the overall curve amplitude becomes a bit lower. The reason is that strain is a relative value and it relates to the baseline length. And if the baseline length becomes bigger, then all the relative values become smaller. And that's the simple truth behind this. All the rest remains exactly the same, and we can even convert one strain into another, so it's not really necessary to make this effort. We can just calculate any strain value which is based on a baseline with pre-contraction state to any strain value which is based on a baseline with end diastole, according to this formula, which you can also find in the recommendation paper. Just to show you the numbers of this example, we would have measured in the pre-contraction baseline version something around 35% of strain with a contraction strain of 13%, and then we get 40% for the reservoir function if we want to know it with the baseline and diastole. So the zero reference to repeat that is end diastole. Why? Because it's easier. All strain programs use it and it's easily available. It even works in atrial fibrillation. We do not need a P wave and an atrial contraction. And since we can convert it anyway into the other version, there's also no practical need for doing it differently. So now we come to a more difficult question. What is the clinical value of atrial strain? It's a rather new field of research, although there is growing interest in it. And there are several studies that have looked into that, although when we think of our own expert consensus statement that we wrote 2011, then at that point in time, we clearly stated that left atrial strain is something that is not ready for clinical use, and very similar wording was used for the right atrial strain. Also here, that there is much more validation work to be undertaken before this can be considered a routine clinical parameter. Nevertheless, a lot of people have looked into that because it's a very interesting topic, and I will show you a few studies in the following minutes. A lot of people have looked into the use of left atrial strain in the context of left ventricular diastolic dysfunction, heart failure with preserved ejection fraction, and such things. And I show you here one work that has compared filling pressures of the left ventricle with the atrial strain. And you see here that there is a reasonably good correlation in this study, not perfect, but there is some connection between the two. Another study has done the same, left atrial strain to detect left ventricular end diastolic pressures above 16 millimeter mercury. Also here they found that there is a meaning in the strain measurements, especially in the left atrial reservoir strain, which you can see on the left. There seemed to be a rather clear cutoff of 31% to distinguish elevated and non-elevated left ventricular filling pressures. That was a smaller study, but nevertheless, it's an interesting result. And this is a somewhat bigger study which did similar things here. They looked into the diastolic dysfunction grades according to the diastolic guidelines, which are graded from 0 to 3. And they tried to find cutoffs to distinguish grade 0 from the others, which is shown on the left, or grade 1 or lower from grade 2 and higher in the middle, or grade 3 from the others, which is shown on the right side. And for all these distinctions, you can define a cutoff value. And it's interesting to look at these values to get a feeling for what left atrial strain means. So 40 is the normal value. If we want to distinguish no atrial dysfunction or no diastolic dysfunction from the rest, then 35 would be the cutoff. If we want to distinguish mild diastolic dysfunction without elevated pressures from elevated pressures, then 24 would be the cutoff. And if you want to identify severe diastolic dysfunction, then 19 would be the cutoff values, with rather high areas under the receiver operating curves. Other studies have looked into the relation between left atrial fibrosis of the atrial myocardium and the strain, and they found a relation between the two. You see here a study in 65 patients with permanent and intermittent atrial fibrillation, and you see clearly in this example that the atrium with a lot of fibrosis, which is shown in green here, has the lower strain, and the atrium which has just a little bit of fibrosis has the higher strain values. And that brings me back to the case which I started with in the very beginning, because this patient did not only have bypass operation in 2015, but during the surgery he was also cured from an atrial fibrillation. So he got a Cox-Maze procedure, and he also got a clip into his atrial appendage. So this patient has a lot of extensive scarring of the left atrium, and he has a reduced left atrial function, and that explains why we have these low A waves. And also, if we look at the strain of the atrium in this patient, then we see that the strain is severely reduced, both in the reservoir phase, so at the peak here, and also this contraction strain is very, very low, with only 4%. If we continue with studies, then we should mention this paper, which has compared the fibrosis quantified by biopsy to strain values. And also here they found a correlation between the strain values, and that was the peak strain, so the reservoir strain, and the fibrosis degree according to histology. What is striking, however, you should also carefully look at these images here, because what you also see is that the more severe these patients get their mitral regurgitation, the more severe they also remodel. So you see that the atria become bigger and bigger with the decreasing strain value. This is something you should keep in mind for the following minutes. And since we were talking about mitral regurgitation, this is another study that looked into that, and on average they found that the atrial strain was increased in patients with mitral regurgitation. On the left side you even see strain rate values, so this was from Doppler times, but also the strain on the right side is elevated. On the other hand, they also found that on average in this patient group there were elevated atrial volumes in this patient. The interesting thing is, however, when you look at the degree of severity of the mitral regurgitation, then you see that it's not so straightforward, because there was actually a biphasic response of atrial strain. The atrial strain indeed goes up with mitral regurgitation, but if the mitral regurgitation becomes more severe, then the strain goes down again. And this is due to the fact that the volumes go up and the atria become bigger and bigger in a more diseased state, so the relative deformation of the atrium becomes smaller. Another study here that looked into atrial strain as a marker of subtle function changes of the left ventricle. Nowadays we have, of course, left ventricular strain, so we can also measure subtle function changes directly, but also in the atrium you get these reflections of dysfunction. These were patients with normal atria, and despite of that they had reduced atrial strain values in hypertensive disease and in diabetes mellitus. I have several times mentioned that it's a challenging topic, and I would like to show you some reasons why I think it is like that. If we think of what we are tracking when we track atrial strain, then we should not think of an echo image like this. I would like to turn it around for you, because you are not used to this image, except of the pediatricians amongst you. And if you look at this image, you get suddenly very scared how bad the image resolution is at the far field of the image. There is hardly anything that you can track. There is something white, and there is some white clusters that move a little bit back and forth, but this is not really speckles that you can track. So what we are doing when we are doing strain measurements in the atrium, we are basically doing a contour detection between the black atrium and the white myocardium, and this is what gives us the length change of the myocardial contour. The other thing is, can there be or is there added value in the strain of the left atrium? When we think of the motion of the atrium, the link to the left ventricle is the mitral ring. So both the ventricle and the atrium are connected, so they behave very similar, actually inverted. When you look at these two strain curves from the atrium and from the ventricle, they mirror each other. So is there added information in it? We have looked into this in a large study, in a retrospective study in Leuven, where we screened more than 1,500 patients from our echo database. And we tried to measure ventricular and atrial strain in those patients with limited feasibility, 76% for the global strain in the ventricle, which is probably the usual value that you would expect in the clinic. But for the left atrial strain, it was much more difficult to find images that were good enough for that. In the end, by excluding all the patients with exclusion criteria, we ended up with 127 patients, which had very clean images from the ventricle and the atrium, which had no valve dysfunction, and which had a wide range of systolic and diastolic function. And what I show you on the right side here is a diagram that brings together the left ventricular strain and the left atrial strain. If you put these two values together, then you create a loop. And you see that this loop is very narrow. It's almost a line. And that means that these two strain curves mirror each other. You can also see that here on the correlation factor, this correlation value is 99, so it's close to 1. It's a perfect match, so to say. What is also interesting is the slope in this equation, and this slope is around 2, which makes absolutely sense when you think of a strain value in the atrium of 40 and of 20 in the ventricle. But this is something that depends on the clinical condition. If we have a normal heart, then indeed we have this factor of 2, but if we have, for example, a heart which has big ventricles but not so big atria, then the slope changes, and it changes in the other direction when we have a heart where the atria are very big and the ventricles are not so big. So this slope tells us something about the strain relation, but it also tells us obviously something about the volume relations of the two chambers, and that makes absolutely sense because these two chambers exchange volume with each other, so it makes absolutely sense that these strain values are inversely related to the volumes. And we have put that together. You see here the slope of the atrial ventricular strain loop, and on the other axis you see the volume ratio of the left ventricle and the left atrium. And just by using the left ventricular strain and the volume ratio of the two chambers, we can predict quite well the left atrial strain. So these numbers tell us, these correlation factors tell us that the reservoir strain is to almost 90% determined by left ventricular systolic function. The conduit strain is to more than 80% determined by the conduit strain in the left ventricle, and the contraction strain in the left atrium is also to 80% determined by the contraction strain in the left ventricle. And what is remaining is then the potential added value on top of other echo parameters. We have also added other echo parameters like elevated left atrial pressure, A waves, peak A of the mitral inflow and other things, and we could get that a little bit better with that, but the values remain in the same range. So more than 90% of the reservoir strain, for example, can be modeled by regular echocardiographic measurements that we routinely do in the clinic. So the remaining part could be the added value, or it could be just noise. So, ladies and gentlemen, I would like to summarize that left atrial strain is something that reflects a very complex interaction of, on the one side, left atrial myocardial function and compliance, on the other side also the volumes of the left atrium and the left ventricle, and the loading conditions, the pressures that occur during the cardiac cycles in these two chambers. It looks like that the left ventricular function and the volume ratio between the chambers are the dominant factors, and the other parameters account for around 10 to 15%. LA strain measurements are not straightforward. It's a challenging task. They can be also quite variable. And this is something which we need to determine in the future, how feasible and how reproducible these measurements are, that we can use them if we can use them reliably in a clinical setting. But nevertheless, despite of all these challenges, atrial strain is something that's currently under clinical evaluation and under investigation by a lot of researchers. There's increasing interest in that. And we have to find out where we have clinical areas where the assessment of strain really provides added clinical value. Thank you very much.
Thank you, Jens-Ove. Excellent presentation.
I wanted to add one more slide because I also want to make an announcement. If you're interested in myocardial function, if you're interested in physiology and pathophysiology and latest advances in imaging technology, I would also like to invite you to a meeting that happens in the beginning of February 2020 for the 22nd time in Leuven. Thank you very much. Sorry.
Thank you. So there is an immense interest in the audience about atrial strain. We have to remember our title of this webinar, how and why to measure. So now comes the key question for you, which also has come from the audience. Why measure atrial strain?
Yes, this is a very valid question. I must say I tried to answer the how, and I focused a bit on the how because this is the easier to define part. If there is added value of left atrial strain remains to be determined. We have a lot of studies that point in that direction that show us that there might be something in it, for example, in the context of diastolic dysfunction or heart failure with preserved ejection fraction. And even if the left atrial strain does not really add added value on top of a lot of other echo measurements that we can do, even then it might be a valid parameter because it could give us an easy summary of the condition of a patient. So it doesn't need to have added value. It's just more maybe easier and faster to measure this one value instead of 5 others. So maybe there's something in it, but that needs to be determined still.
Luigi, do you have a comment to that?
Probably I would be a little bit more positive than Jens-Ove. I think that indeed in the assessment of left ventricular diastolic function, particularly when we have to differentiate cardiac from non-cardiac origin of dyspnea, there is a role for left atrial strain.
Yeah. So it's we should continue to measure it because we will have, maybe there will be an added value. Can you maybe explain a little bit or talk a little bit about your ongoing projects and your...
Yeah, it refers to both, actually.
Yes.
We are both in this task force for the standardization of strain, and this has also generated all this work in these fields, and we will go on with that. And we will set up another inter-vendor comparison study, because a lot of vendors come out now with new software for measuring right atrial and right ventricular and atrial strain. And we will set up another inter-vendor study to see how the field develops in that direction.
And then we will try to address the three-dimensional strain that is the new stuff that is going on.
The new hot stuff. Okay, we are now approaching the end of this webinar, and I would like to close this session by summarizing the key messages for your daily practice. Right ventricular longitudinal strain is an objective, more sensitive and less load-dependent parameter of RV systolic function than conventional parameters. RV longitudinal strain is significantly related with disease severity and outcome in patients with various conditions affecting the RV. And for example, conditions like pulmonary hypertension, in certain cardiomyopathies like the arrhythmogenic cardiomyopathy, and in patients with inferior myocardial infarction. Atrial strain is currently under clinical evaluation. Areas where the assessment of atrial strain provides added clinical value remain to be determined, but potential conditions, as we have heard, could be heart failure with preserved ejection fraction, and not mentioned, but maybe also patients with atrial fibrillation and evaluated for cardioversion or ablation. And by this, I would like to thank Professor Badano and Professor Vogt for your presentations, and thank you and all of the audience for joining us this December evening. You will be able to watch this webinar on demand on the EAC website. Thank you very much and good evening.
Thank you.